First of all, Tavish and the Pollen Healthcare team to give me this opportunity today. My core interest lies into many specialities, critical care being the primemost. So I'm very happy to be here today. So probably our fellow dietitians, students, and all of us should know in brief what it is, and then take a decision on how to go about on it. The disclaimer: this particular presentation is intended for educational purpose and does not replace any independent professional judgment of anyone, and no conflicts of interest or restrictions related to the presentation. Well, the learning objectives includes challenges and pathophysiology of critical illness. That is very important to understand, and the importance of nutritional support in critically ill patients. Benefits of enteral nutrition. Obviously, we all know that it is important, and why early enteral nutrition is important. Recommendations and guidelines, which are the recent evidence-based guidelines that we'll be talking about, and not to forget types of enteral feeds and some key learnings before we finish the presentation. To understand, basically, as dietitians or clinical nutritionists, what are the challenges that we are facing in critically ill patients to achieve their optimum nutritional requirements is they undergo, the patients in critical care units, they undergo a lot of various physiological and metabolic changes when they are being admitted in the ICU setup. And these changes definitely lead to an increase in the risk of malnutrition, or already the patients who are getting admitted are maybe mild or moderately malnourished by itself. So it becomes all the more difficult for us to meet the challenges, meet the requirements initially itself. There is a reduction in the total calories and protein intake, which complicates the condition, the clinical conditions, and the outcome of the patient, because the patient intake, the patient's intake and the patient's requirement don't match up, and that is where the complication starts. Increase in septic shock or rise in inflammatory biomarkers are these very common seen in ICU setups, and the metabolic imbalances basically results into MOTS, shock, and sometimes definitely mortality rate if not taken care of earlier. So up to 60% of ICU patients suffer even GI dysfunction, which is very, very commonly seen, GI intolerances in our ICU patients as well, due to impaired GI motility or digestion or absorption. Such GI dysfunction, often coupled with inadequate calorie intake, leads to critically ill patients developing energy deficit, and they start losing lean body mass faster. To understand the pathophysiology of the critical illness, see, it's a myth if we say, previously well nourished patients getting admitted in ICU take several days for malnutrition to manifest, but it is not so. If understanding in a normal patient, normal person who is in a starvation mode, the kind of process which takes place is ketogenesis comes into the picture, and fat is utilized as a substrate for energy. However, in a patient who is in sepsis in ICU, the patient there the main fat mobilization is impaired, and glucose is not getting generated. In fact, glucose is needed in more amount in these conditions, and glycogen after the liver glycogen is over, the body starts looking at the process of getting it through the muscles. The muscles have around 500 grams, and there is where it start taking the glycogen and breaking the protein. So proteolysis is basically at the maximum, and what happens is glycogen gluconeogenic pathway is into picture. Ketogenesis is not into the picture when the patient is in sepsis so much, and it also takes a lot of days for ketogenesis to or ketosis to get into set into place. So what happens here is a lot of protein catabolism takes place, and the patient is in a hypercatabolic phase. The muscle mass starts to deplete. Well, to understand if the body needs around 100 to 150 grams per day of glucose, how it is being derived and how the body starts losing lean body mass. Around, say, 3.5 grams of glucose, which means around 14 calories, is derived from a gram of nitrogen, which is also called as like 6.25 grams of protein. And how much lean body mass is actually lost if we actually calculate 3.5 grams derived from 6.25 grams of protein, but 150 grams of glucose, which is minimum needed, or say 100 grams is needed, is derived from 270 grams of protein if dry weight is considered. The muscle mass is 60% water. So actually, when we're talking about 270 grams of protein, At the cellular level, it is 675 grams of protein per day that the body is losing or the patient is losing. And that is where the truth actually exists, as in previously well nourished patients. PEM, which is protein energy malnutrition, occurs rapidly at the cellular level and sets in within the first few days itself. Next is to understand the nutritional support. So the nutritional support definitely is needed because the patient is under stress, under acute illness, that is has got admitted with acute illness. Post surgery, post trauma patients definitely have more requirements, and they also have major changes in their metabolic processes in the body. So the changes like in substrate utilization, instead of fat also being used up or glycogen being used up, it is using up the protein more so instead of fat. Altered substance synthesis rates, because there is more proteolysis and there is more gluconeogenesis which takes place, or glycogluconeogenesis which takes place. Hypermetabolism or hypercatabolic phase in the ICU, which definitely makes us think about providing the nutritional support as early as possible to the patient. Understanding the major goals, which helps us to determine the nutritional principles, is acute critical illness, like we already spoke. The degree of catabolism exceeds the degree of anabolism. So definitely we need to be thinking on our nutritional goals, keeping in mind carbohydrates are the preferred energy source since fat mobilization is impaired. Protein prescriptions are also in the hope of reducing the breakdown of muscle proteins into amino acids. However, even if we provide to the requirements, we are not able to match up to the exact requirements of the patient. So it becomes all the more important, and then it serves as a substrate for gluconeogenesis. Phase of recovery is characterized by anabolism exceeding the catabolism. So when the patient is in the phase of recovery, then it begins, it begins definitely when the critical illness starts resolving. And that is again one phase that we have to look at how to provide. So how it starts at the acute phase to the later acute phase to the recovery phase has to be thought of. Importance of nutritional support in critically ill patients? Well, definitely, nutrition support is very important because it helps in reducing the metabolic stress which is being caused, metabolic response to the stress which is being caused by the inflammation. It helps in modulating the immune response of the body, prevents metabolic deterioration, and prevents loss of lean body mass of the body. Of course, it leads to decreasing in the morbidity rates and mortality rates, decrease in length of stay, the total cost of the healthcare, plus improves the patient outcome or the recovery. Now, we need to understand as dietitians that when the patient is getting admitted in the ICU, we need not overfeed or we need not underfeed the patient. We need to feed adequately. When in ICU, we know how difficult and challenging it is to meet the requirements or the targets of the patient's requirements. It is very, very difficult, and there are a lot of distractions or interruptions which happen during the patient's stay in the ICU. So, what are the things that we need to look at and monitor? What are the things that we need to look at when we're looking at insufficient energy intake or excessive energy intake? For the early signs, we have to look at hypoglycemia or maybe hypothermia if it is setting in the patient, or if the patient is having higher episodes of hyperglycemia or hyperlipidemia. Mostly triglycerides are being raised in the blood, or hypercapnia. So we have to look at these symptoms. If it is delayed symptoms, we have been underfeeding the patient for a long time or overfeeding the patient for a long time, we can look for similar kind of symptoms or signs, like infectious complications start arising. So there is impaired immune response of the patient, impaired healing processes. There's a very thin line. There may be loss of lean and fat body mass in an underfed patient, or impaired muscle function and muscle strength of the function. However, there would be liver steatosis because of increased triglycerides and lipids and increased fat mass in the body when we are in the patients, when we are overfeeding the patients. Like I spoke earlier, there is a lot of GI intolerance which sets in the patients who are in the ICU. So why is it important for us to talk about GI intolerances? We know about gut, brain gut axis, and how GI intolerance will also be challenging for us because there will be forced discontinuation of enteral nutrition. We will not be able to provide it once gastric intolerance sets in or there is gastric dysmotility, which is a sign of disturbed GI function in the body. And intolerance to gastric feeding has been reported up to as 60% of the patient in the ICU, which is very, very high. Where do we see that generally in patients who have changes in the body proteins, energy metabolism? Definitely because the patient is in hypercatabolic state. So the inflammation rate at which the patient may get infections or inflammation is definitely higher because the patient is already admitted with it. There is delayed gastric emptying or abnormal motility patterns, if we see, or impaired intestinal barrier integrity. Then there is, we can say, GI intolerance in the patient. There could be fear of complications of gastric reflux as well. So these are things again we need to keep in mind when thinking about GI intolerance in ICU patients, and how it could lead to various consequences is it could lead to diarrhea, it could lead to constipation. The first thing that happens in the ICU, a patient is seen with diarrhea or constipation, they start looking at the feed, what feed has been provided to the patient. And other than that, maybe diarrhea, the frequency in the ICU may vary from 2% to 95%. Or if it is constipation, if you say there is a delay in enteral feed in 50% of the patient just because of constipation, if you see, because there is a delay in feeding of the patient in the ICU. Malnutrition definitely sets in. It increases the length of hospital stay of the patient by at least 4 to 5 days. And what happens is there is impaired gut function significantly, which compromises the delivery of enteral nutrition, resulting into increased hospital stay of the patient. Well, understanding with this particular study, it was seen that 30 to 70%, like I said, ICU patients had GI dysfunction. And what we need to understand is premorbid conditions like TBI, ventilation mode patients were studied, altered metabolic state patients like having inflammation or sepsis or circulating stress hormones or gut hyperperfusion patients were seen, which means altered metabolic state. ICU medications like the patient being on catecholamines or sedatives, opiates, etc. They found that also GI dysfunction happened in patients who were 50% of mechanically ventilated patients. So it is very important for us to understand the GI function in ICU is as compromised as it looks here, and this is all the criteria that we have to look at. Especially patients here, they're more prone to get GI intolerances, and GI dysfunction coupled with inadequate intake of nutrition would lead to malnourishment. When we say malabsorption, intolerance, and leading to calorie energy deficit. 74% of mechanically ventilated patients failed to attain 80% of their energy targets. This is what this particular study spoke about. Nutrition in ICU, basically, what we see is when the patient gets admitted, if the patient is taking orally, if the gut is functioning, then well, fine. We can otherwise start enteral nutrition if not, patient is not able to take orally. It's a preferred method of providing nutritional support to our ICU patients, and definitely more preferred than parenteral nutrition because obviously it is very simple, causes fewer complications and side effects, lower cost than compared to parenteral nutrition, and the ability to protect the intestinal mucosal barrier or intestinal integrity is better. So we need to be considering enteral nutrition prior to PM. However, there are limitations to it, as in feeding intolerances usually occur during enteral nutrition, leading to adjustments or discontinuation of the enteral nutrition. When nutrient intake does not meet the body's metabolic demands, it can lead to malnutrition. The patient starts developing malnourishment or is at a higher risk of malnutrition. Now, when we're considering ICU patients, we cannot just stop without talking about patients who are in post surgery or post trauma or post sepsis. What are the few things that one needs to keep in mind? They are quite similar because they are as per the ESPN and ASPEN guidelines that I've taken here. Surgical patients, post trauma patients, start enteral nutrition early using a high protein polymeric diet for trauma patients. consider an immune modulating formula with arginine or fish oils in severe trauma cases. However, if it's a TBI case, traumatic brain injury, start EN within as early as 24 to 48 hours of the injury. It is definitely going to show better recovery of the patient, and use an immune modulating formula or supplement, having EPA or DHA. Open abdomen or major surgeries, patient with major surgeries, it is very important to determine the nutritional risk right at the initial phase and start enteral nutrition within 24 hours of surgery. In the absence of a bowel injury, start enteral nutrition as early as within 24 to 48 hours post the injury. Now, when we consider sepsis or the patient is in septic shock, it is very important to know that the patient is hemodynamically stable prior to starting our intervention. So, start enteral nutrition within 24 to 48 hours of diagnosis when resuscitated, and avoid parenteral nutrition in the acute phase of sepsis, regardless of the nutritional risk. The main preferred choice would be definitely enteral, but in acute phase, avoid parenteral, even though there is a nutritional risk involved. Trophic feeds is something that probably can be started with patients in septic shock. So it could be as little as 10 to 20 ml, probably can be started as trickle feeds. And during the initial phase of sepsis, probably something which is lesser than 500 kilocalories per day can be started. There, our main concern is not reaching the targets, but our main concern is to move the gut. Um, Advance after 24 to 48 hours to more than 80% of the target over the first week of feeding the patient. Of course, the protein requirements could be 1.2 to 2 grams protein per kg per day and can be calculated according to this. Now, what does the international guidelines on nutrition talk about? If we consider ASPEN or SSCM, which is Society of Critical Care Medicine, 2016 guidelines talk about energy requirements being 25 to 30 kilocalories per kg per day. That's our thumb rule that we use. In patients who are obese, which means the BMI is between 30 to 50, we need to use 11 to 14 kilocalorie per kg adjusted body weight per day. And if the BMI is more than 50, you can calculate probably 20 to 25 kilocalorie per kg ideal body weight per day. Similarly, ESPEN guidelines also talks about obesity, then 20 to 25 kilocalories per adjusted body weight per day. Protein requirements at the ASPEN guidelines say 1.2 to 2 grams per kg per day. If the BMI is between 30 to 40, then 2 grams per kg ideal body weight. If the BMI is equal to more than 40, then up to 2.5 grams per kg idle body weight per day. And similar to that, ESPEN says 1.3 grams per kg per day. And when it should be commenced, I think both are quite similar, that it should be as early as possible within 24 to 48 hours of the patient getting admitted. Recommendations from Indian practice guidelines are enteral nutrition should be started as early as possible, preferably within the first 24 to 48 hours. Tube feeding should be considered if even 50 to 60% of the nutrition targets are not met adequately within the first 72 hours of oral nutrition support. And if the nutrition requirement is not met adequately with EN also, even after 7 days of ICU admission, then probably use of partial parenteral nutrition may be considered, supplement it. Importance of micronutrients, it is very important to understand micronutrients. Well, if our patient is having balanced or an optimum complete balanced formula feed, then probably we may not need the additional micronutrients, trace elements and vitamins, but pre-existing micronutrient deficiencies needs to be assessed and evaluated probably by your consultant or doctor as well, and could be supplemented in patients maybe who are on blenderized feeding, who are using blenderized feeds in their hospital setups, or those who are on parenteral nutrition. The preferred route of nutrition is very important. Definitely, we prefer, if the gut is functioning, enteral nutrition is preferred over parenteral as early nutrition in ICU patients. Supplemental PN at the end of first week of admission in ICU is advisable when food enteral nutrition support is not possible, or it is it fails to deliver the energy targets up to at least 60%. However, combination should not be routinely recommended except for basic specific indications, which may be an unconscious patient like of a head injury, ventilated patient, swallowing disorders, which could be some neurological disorder, say physiological anorexia in liver cases, upper GI obstructions with some strictures or obstructions, partial intestinal failure, like IBD or short bowel syndrome, increased nutritional requirements like renal diseases, or psychological problems like severe depression or anorexia nervosa. So in these cases, probably we could be looking at even a combination. But otherwise, routinely on a routine basis, there it is not recommended. To understand nutritional management in terms of the nutritional status of the patient. What is the nutritional status? First we need to screen the patient, we need to assess the patient based on the various tools which are available. Now we also have an IAP tool which is recently been come up with some screening tool, other than I think SGA, which is being prominently being used and is the gold standard to be used, or NRS 2002. So once we have assessed the patient and we know the patient is well nourished or moderately malnourished, in the acute phase, we try to consider enteral nutrition and not use parenteral nutrition. Our energy targets would be somewhere less than 70% estimated or measured, which means we know the target and then less than say 70% is what we need to start with. Protein targets definitely except the protein dose provided by delivering the energy target, so that our protein is not being used up for the proteolysis which is happening. Our proteins are being used up for building on, and we are not losing on the lean body mass. That is important. So we have to keep the targets in mind. Severely malnourished patients, follow management for well-nourished patients. That is important one. And closely look for signs of refeeding syndrome, especially if we see hypophosphatemia or even low levels of thymine. If phosphate is low, replace, keep energy in target to less than 50% requirements for the initial first 2 to 3 days before gradually increasing it. And at the acute late phase, we need to keep in mind it has to be enteral nutrition definitely. PN if EN is contraindicated only in those cases. It depends on case to case. And energy target could be between 70% or 80 to 100% estimated measured requirements. We need to gradually increase the proteins to 1.3 grams per kg per day. In case of severely malnourished patients, it is similar, but we continue to be watching for the signs of refeeding syndrome. Recovery phase, when the patient has been in the ICU for more than 7 days, probably we have to look at the recovery phase. And in the same, also we provide enteral nutrition as a first choice, commence PN if EN is contraindicated or insufficient, and then try to reach the target 80 to 100% by either using IC, which is indirect calorimetry, or by by thumb rule or predictive equation, because we presently use that only. We don't have indirect calorimetry at our setup. So, nutrition monitoring in critical care, how important it is, not just to write it, but also to monitor is important. What are the things that one needs to keep in mind? Identification of patients at risk of feeding intolerance will help in development of strategies to monitor and manage nutrition intolerance and reach to their targets. So that will help us only if we are monitoring it, right? So this will ensure adequate delivery of nutrients to our ICU patients. What are the recommendations for the same? Versus gastric residual value, it should be measured by syringe aspiration and not by suction pumps. That is very important. And if it is used, it should be less than 300 ml. If it is less than 300 ml, then it can be refed if it is not blood stain. Holding enteral nutrition for GRVs less than 500 in the absence of other signs of intolerance should be avoided. This is as per the guidelines. However, every hospital has their own local policy or set policy for it. It could be a cutoff range between 300 to 500 ml, which can be considered. In case of high GRVs, efforts should be made to continue feeding with reduced volumes. Prokinetic agents could be used like erythromycin or metoclopramide, can be recommended for the patient intolerance and risk of aspiration. Of course, nurses should be trained well for monitoring intolerance. At present, we have put up an ICU alert guideline where we have put up posters in our ICU, and where it talks about the elevated bed, the evaluation of the GRVs, all those things in the chart itself, and we keep training the nurses about the same, how it has to be given, how the feed has to be reconstituted, which we do at bedside in our ICU setup. So all those points are being considered there to have safe and hygienic practices also while having enteral nutrition for our patients. Nutrition protocol for ICU, basically one needs to keep in mind. This is a kind of a busy slide, but I would just put it as, we need to have an ICU bundle, nutrition ICU bundle in place, wherein we need to be talking about once the patient is hemodynamically stable, then we are definitely looking at the nutrition protocol. When we are looking at that, the first thing that should come into mind is the screening of the patient and the assessment of the nutritional status of the patient. After assessing the patient for malnutrition, probably we can calculate and plan our requirements of the nutrients, how and what we have to plan for the patient. Once we know that this is the target for today, or if your patient is taking orally, excellent. If the patient is not taking orally and we have to shift to enteral nutrition, whether it can be started, no, it cannot be started, then we need to start parenteral nutrition. We have to talk to our consultant about it. If we can start enteral nutrition, then we have to talk about if it can be oral and enteral or just enteral nutrition. We could start with having where is the route, what is the route, where is the tube being placed, and how much is our targets that we have to reach to. Depending on that, the condition of the patient and what kind of formula will you suggest to the patient, the planning and uh, calculation of all those things. Once you've planned your nutrition care plan for the patient, then probably your monitoring and evaluation comes into the picture, and your progressively reaching the goal is becomes important. So what is important is starts with 60% to 70%, and then gradually increases progressively to normal feeds. We can start with standard polymeric formulas. We don't really have to stick along to any specific formulas all the time. And trophic feeds of 10 to 20 ml probably could also be started in case we see any kind of GI intolerances. Other than that, continuous monitoring, continuous evaluation of it, and managing the nutrition requirements of the patient becomes extremely important. In case we see any kind of any kind of aspiration in the patients, the use of prokinetics or head of the bed to be elevated to 30 to 45 degrees becomes important. Use of post-pyloric route of feed, if needed, has to be considered. Maybe to avoid VAP, use chlorhexidine mouthwash. All these things probably are also taken care by the nurse. But these things are things that we need to also monitor along with our nutrition calculation. Now, why to start early nutritional or enteral feeds in ICU patients? Definitely, our study and lot of studies and data says that malnutrition in the ICU ranges from 38% to 78% and independently associated with poor outcomes or poor recovery of the patient, increasing the length of stay of the patient in the ICU. One third of the patient getting admitted in the patient hospital are in the malnutrition condition in developed countries, whereas one third hospitalized patients become malnourished during the hospital stay. So it is as high as that. And, the patients averagely lose around 2% muscle proteins per day, with understanding how much is the protein requirements in the ICU. Comorbidities significantly increase the ratio of readmissions of the patients, included weight loss, iron deficiency anemia, or malabsorption and malnutrition sets in. What are the factors one needs to keep in mind when prescribing enteral nutrition in critically ill patients? Well, limitation of microbial contamination of feeds. We need to be taking care of bacterial contamination by having safe and hygienic preparations and reconstitutions of the feeds. That is very, very important. Meeting adequate nutritional needs safely. So the planning is important, and not just the planning on the paper, but if the patient is receiving it or not. So that in case of any distractions, disruptions, or interruptions, we need to make sure that we are adjusting and the patient is also achieving what the patient is losing, and we are trying to compensate that. Ease of use and convenience for the nurses, because the nurses are the most busy person when it comes to ICU or ward. They are taking care of each and everything. So we need to keep in mind as dietitians, as hospital dietitians, that we are planning the timings or the feeds as per their convenience and comfortability, so our patient gets it and it doesn't get delayed because of their work timings. So we need to be planning, and every hospital, I'm sure, has some plans for it. Cost effectiveness is very important because the patient is undergoing and the healthcare costs are so high, then we need to be considering even cost effectiveness to see that we are providing the patient adequately with cost effective plans or availability of these. Types of enteral feeds. Well, there is blenderized foods and there are scientific foods. When it comes to blenderized, it is our old traditional, old-fashioned feeds, kitchen feeds, wherein we try to blend, rice, or we try to blend dal and rice. We add oil, we give milk. We used to give buttermilk and lassis, but these are all things which are old now, and the latest the current guidelines, which are not so current, they have been old enough for us all to implement it already in our hospitals, that we should be using scientific formulas, because they are claiming to be advanced, but they are not actually advanced. They have a lot of limitations, especially that they could be having high microbial or bacterial contamination chances or risks. Okay, inconsistency in the amounts and the supply of nutrients is 16% to 50%. The person who's making it, the cook who's making it, variability in it, check of it is very, very important, which is not there. Even the consistency changes and the texture changes. High osmolality and viscosity, possibility of a blockage of the feeding tube, again causing a lot of inconvenience in for the patient. What are the potential contraindications for the same? Acute illness or immunosuppression, greater risk of infection from contaminated food, which can result into fluid restrictions, may be difficult to meet nutrient needs. If there are fluid restrictions in the patient, you'll not be able to achieve it. And that is going to deteriorate the condition of your patient with having a long-term stay in the hospital. Continuous feeding requires formula to be probably unrefrigerated for several hours. So all that has to be kept in mind. How is the feasibility? Definitely it's not a go kind of a situation. We have to look at enteral scientific formulas. So when we talk about scientific formulas, there are many. We can probably put them into the group of polymeric, disease specific, oligomeric, immune modulating and modular products. Well, what we use in our setups are the balanced complete polymeric formulas. They contain whole protein or intact protein as a nitrogen source, and the content of these products could vary greatly in terms of caloric density, macronutrient distribution, amount and type of fiber being added into it, or vitamin or mineral, and electrolyte composition. Also, the subtypes could be standard, high protein, energy dense, fiber enriched. So standard could be used for normal GI function. Nutrient distribution is as good as normal diet. High protein could be protein would be more than 15% of the total energy being provided, and it could be used in wound healing cases or probably catabolic states, trauma cases. Energy dense could be 2 kilocalorie per ml. So all are 2.0 products, which are their scientific formulas, probably would be the energy dense ones, especially could be used in patients who have fluid restrictions and electrolyte imbalances. Fiber enriched would be 5 to 15 grams. Bowel function disorders, where we can probably use these as well, a part of the plan that we have. Whatever you're giving, along with that, you can add on the fiber enriched ones as well. Next is oligomeric. So when we talk about oligomeric, these are proteins which are hydrolyzed to peptides or amino acids, elemental, or probably a combination. Generally, what we have is a semi-elemental based one, and composition would vary again here. One or more nutrients are hydrolyzed and suitable for patients with extensive impairment of gastrointestinal function. Generally, it is suiting with patients with any GI dysfunction. Also pancreatic disease or diarrhea, persistent malabsorptive diseases. So definitely the absorption or the bioavailability is better if you use this product there. Disease specific, it could be renal, hepatic, pulmonary, diabetic, etc. It depends on if we have a renal failure case, less protein, low electrolyte, we can go for renal case specific formulas. If it is hepatic NCAF, probably high branched chain amino acid and lower aromatic amino acids. Low electrolyte one could be used. ARDS, definitely higher fat content and high probably protein, moderate carbs could be used. Diabetes mellitus, a low carbohydrate, low supplement could be used. It again has the contents which would greatly vary in terms of calorie density and macronutrient distribution, amount of fiber or vitamin mineral. and electrolyte composition. Now, next is immune modulating. These are ones probably which have combination of pharmacologically active substances such as arginine, glutamine, omega-3 fatty acids, linolenic acid, nucleotides, antioxidants, and they are intended to modulate the immune response or the function of the body. Now, with these molecular products contain predominantly one nutrient, and they could be used probably protein, carbs, lipids, or fiber. Coming to bovine colostrum and its effects on critically ill patients. Now, to understand what is bovine colostrum, whether we use it or not is a different aspect. But as our, as in dietitians, we should just know about it because there are many products which are coming up with bovine colostrum now. So, what is it? Is one thing. Bovine colostrum is the first milk which is produced after birth, commonly referred to as baby's first milk or biological soup. It's a rich source of micronutrients and immunoglobulins, peptides with antimicrobial activity and growth factors. You can see the difference between colostrum milk and the whole milk, which is on the 11th day, how it is differing. The total solids or the total proteins, it varies how much. So it varies at least 3 times to 3.5 times in proteins. Immunoglobulin 6 times it varies. So definitely it is higher in that. And that is what is probably needed in ICU patients is what is thought of, especially for GI intolerances patient or our respiratory distress patients. What makes bovine colostrum so beneficial? Well, there are over 90 known components in colostrum. The primary components are divided into two classes mainly. One is the growth factors and the other is immune factors. These are two important prime factors. And colostrum has precisely balance of vitamins, minerals, amino acids in a perfect way to have synergy to restore and maintain health. These are particularly the nutrients which are found in bovine colostrum. Some vitamins and minerals which are mentioned here: B1, B2, B3, B6, pyridoxal, B7, B12, vitamin C, A, D, and K, minerals like calcium, sodium, potassium, magnesium, zinc, and copper. Sugars would be lactose and oligosaccharides. Again, proteins would be caseins, whey proteins, growth factors, cytokines, all immunoglobulins are there. Glycoproteins are there, like lactoferrin, which is extremely important. Lipids, again, all sorts of lipids, whether it is short chain, medium chain, saturated fatty acids, or whether it is conjugated linoleic acid, MUFAs and PUFAs, etc. They all are definitely giving us a nutritional, constructive, and energetic perspective, and they are helping in immune modulation functions, improving the immune response of the body, have antioxidant effects, and also act as prebiotics. So, lactoferrin, which is the prime most important glycoprotein from bovine colostrum, has so many functions by itself. Of course, immunomodulation, that's its prime function. Inhibition of immune response, which is anti-inflammatory, and stimulation of the pro-inflammatory state. Ability to chelate iron, which is very important. So participation in iron absorption and metabolism from the intestine, or participation in redox, inhibition of pathogen or bacterial growth is what it how it helps. Antimicrobial activities against bacteria, fungi, viruses, etc., and other activities by inhibiting tumor growth, wound healing, regulation of intestinal functions, prebiotics, etc. Also, one study also mentioned about a study which was in 2023 only. I came across this particular paper wherein it actually showed about what are the various medications probably being used up in the ICU: antibiotics, sulfonamides, infection care may, probably NSAIDs in inflammation, fever, and pain care, corticosteroids in inflammation care, psychophysical stress related medications. Now, these are things which are already being there in the ICU setup. So what we think is probably the effect of bovine colostrum being systemic effect on antimicrobial, anti-inflammatory, antipyretic, and analgesic agent. In that, mainly the lactoferrin and the bovine colostrum by itself has probably a preventive effect against the adverse effect which is shown by these medications. Like medications like antibiotics may have abdominal pain, diarrhea, maybe gut dysbiosis, etc. NSAIDs would have renal, pulmonary, liver, neurological effects, and damage of gastric and intestinal mucosa. Corticosteroids and other stress-related medications would impair the immune system or cause injury to it. Gastritis, very, very common with it. So these lactoferrin derived peptides, or these lactoferrin and even bovine colostrum and other bioconstituents of it, help in preventing and supporting reducing the side effects of these medications. So there again, it shows a little positive effect. Now, just to understand the immunoglobulins and their effect, obviously we know that immunoglobulin is going to have a better immune response in the body. So IgG neutralizes toxins and including viruses, bacteria. IgM destroys bacteria. IgD is again an antiviral. It is involved in hemolytic disease in infants, prevents immunoglobulin E, generally involved in regulating allergic responses, highly antiviral and antibacterial. When it is IgA, again, mucous membranes, helps in maintaining skin and protects against any kind of infections. When it is lactal albumins, it raises brain serotonin levels, improves the mood under stress levels, also shown to cause lung cancer cells to create selective suicide apoptosis. So apoptosis, as in we probably have the cell cancer cells, dying, and it helps in probably more increase in the cancer cell synthesis. So there we can have look at this use of this particular component of bovine colostrum. Cytokines again is including interleukins or TNF or lymphokines, antiviral, increase in T cell activity. It helps in having a pro-inflammatory response, improves the immune response by regulation and intensity of it, and stimulates the production of immunoglobulins in the body. Again, lactoferrin, it's a powerful antioxidant, antiviral, antibacterial, and anti-inflammatory. So these are components of bovine colostrum. This particular was a study that I found, probably a 2018 paper, in effect of early enteral bovine colostrum supplementation on intestinal permeability in critically ill patient. It was done basically a randomized double-blind placebo-controlled study. The objective was to understand how it affects the effect on intestinal permeability, which they studied by understanding the plasma levels of zolunin. This is again a protein which is found in the intestinal lining, mucosa. So what they found is results showed that bovine colostrum supplementation was able to reduce the plasma zolunin level, which generally increases during the inflammation. A study also reported 20 days of bovine colostrum reduces stool concentration of zonulin in athletes. And intestinal permeability, it showed in subjects whose intestinal permeability rises due to various pathologies and helps restore gut status after the use of antibiotics and NSAIDs, both of which can increase intestinal permeability. So it showed a reduction in that when used bovine colostrum. The majority of ICU patients have at least one of the GI symptoms during their ICU stay, which we have seen also. Results have shown that enteral bovine colostrum supplements reduces the incidence of diarrhea. In this particular study, bovine colostrum was significantly more effective in protecting a healthy adult volunteers against the development of diarrhea caused by E. coli. Bovine colostrum has been reported to positively influence infective diarrhea also, both in human and animal studies. There was another study that I found, this particular study, early enteral nutrition with bovine colostrum in critically ill patients. Now, here particularly, the conclusion was results provide evidence that bovine colostrum supplementation had beneficial effects on intestinal permeability and gastrointestinal complication in ICU hospitalized patients. It's again one of the studies or the papers related to the previous study, both in respect to intestinal permeability. Next, I found one more, which was in 2021 bovine colostrum application in sick and healthy paper. It was a systemic review basically. So what it showed was that particularly it was conducted to update current knowledge on bovine colostrum effects during all administration routes on healthy and sick subjects. And what they found was that it highlighted multiple clinical applications of bovine colostrum and confirmed some general benefits on intestinal and respiratory recovery in absence of adverse effects. And bovine colostrum seemed to promote immune system enhancing and modulating local and systemic responses in various clinical and non-clinical conditions. So this was one particular study. Again, it was related to that. But furthermore, they said that well designed studies are needed to support the administration of bovine colostrum in adult, pediatric, clinical, and non-clinical settings. It is still needed. More studies are needed. One paper that I came across in European Journal of Nutrition to August 2003 reported that an investigation of whether concentrated bovine colostrum affected the incidence or duration of self-reported symptoms of upper respiratory tract infections in adult males. Based on the self-reports in a double-blind placebo-controlled study, preliminary evidence was found that concentrated bovine colostrum protein may enhance the resistance to the development of symptoms of respiratory tract infection. Coming back to our point of understanding the various guidelines for ICU patients, Aspen or Society of Critical Care Medicine 2016 guidelines, to understand once again and reiterate on it, it suggests determination of nutrition risk by using various screening tools. I would also suggest all of you to look at the IAPN tool, which has been come up recently, for whom volitional intake is anticipated to be insufficient. High nutrition risk identifies patients most likely to benefit from early enteral nutrition therapy. We also suggest that nutritional assessment that includes an evaluation of comorbid conditions, functions of GI tract, and risk of aspiration. No using traditional nutrition indications or surrogate markers to assess basically anything. There is no single surrogate marker for the same. Suggest IC or indirect calorimetry to be used, or maybe a published predictive equation or simplistic weight-based equation of 25 to 30 kilocalories per kg per day to be used to determine the energy requirements. Also suggest an ongoing evaluation of adequacy of proteins. However, 1.2 to 2 grams per kg per day is being advised, maybe higher in multi-trauma or burns patient. Initiate enteral nutrition within 24 to 48 hours of ICU admission, and preferred choice of use is enteral nutrition over parenteral nutrition. In critically ill patients with high risk of aspiration or intolerance to gastric enteral nutrition, maybe the level of infusion should be diverted to low GI tract, which means post-pylori. Suggests that also it suggests that in case of hemodynamically unstable patients, enteral nutrition should be withheld until the patient is fully stable, and then it should be started with trophic or full nutrition by enteral nutrition. Is appropriate in patients with ARDS or acute lung injury. And those expected to have a duration of mechanical ventilation of more than 72 hours, we need to be recommending trophic feeding or full nutrition by enteral nutrition. Patients with high risk nutrition risk should be advanced to reaching targets of more than 80% of the estimated energy and protein goals within the next 48 to 72 hours in order to achieve benefits of enteral nutrition over the first week of hospitalization. Suggests also that in patients who are at a lower nutrition risk, for example, if the score NRS 2000 is more than equal to 3, less than equal to 3, or Nutrix score is less than equal to 5, exclusive parenteral nutrition should be withheld over the 7 days following ICU admission if the patient cannot maintain volitional intake and if early enteral nutrition is not feasible. Key learnings that we need to take away today: critically ill patients undergo many physiological and metabolic changes and that result in impaired GI motility, digestion, or absorption. Such GI dysfunction, often coupled with inadequate calorie intake, leads to development of an energy deficit and obviously loss of lean body mass. In such patients, enteral nutrition should be started preferably within the first 24 to 48 hours, and it should be considered even if 50 to 60% of nutrition targets are not met orally or adequately within the 72 hours of oral nutritional support. Blenderized feeds definitely have limitations such as high microbial contamination, high osmolality, viscosity, and inconsistency in the amount and supply of nutrients. Maybe possibility of a blockage of the feeding tube as well. Therefore, scientific formula feeds are preferred over blenderized, and especially in the ICU setup. To meet the nutritional management goals, critically ill patients need scientific formulas, and these formulas promote GI tolerance and deliver the specific nutrients that promotes healing and help in better recovery and outcome of the patient. These are my references. Thank you for a patient listening.